My name is Kate, I'm a physical therapist, and today let's continue the topic of sciatica rehabilitation. In today's episode, I would like to tell you about sciatica from spondylolisthesis. It is quite rare. From my experience, this cause of sciatica occurs in roughly 1 in 20 patients, maybe even less, but it happens. And when it happens, we need to know what exercises to use, because rehabilitation protocol in sciatica from spondylolisthesis is totally different than in sciatica from discopathy. The exercises that I showed you in my previous movie about discopathy, which are based on hyperextensions of the lumbar spine, if used in spondylolisthesis, will usually worsen the case. So today, sciatica from spondylolisthesis. Stay with me. What is a spondylolisthesis? In spondylolisthesis, the vertebral body shifts in relation to the one above. In other words, spondylolisthesis is a slippage of one vertebral body with respect to the adjacent vertebral body, causing mechanical or radicular symptoms or pain. There are a few grades of spondylolisthesis as follows. Grade 1 is up to 25% slippage, grade 2 is up to 50% slippage, grade 3 is up to 75% slippage, and grade 4 is up to 100% slippage. If there is more than 100% slippage, it is known as spondyloptosis or grade 5 spondylolisthesis. Spondylolisthesis most commonly occurs at the L5-S1 level with an anterior translation of the L5 vertebral body on the S1 vertebral body, as you can see over here. The L4-5 level is the second most common location for lumbar spondylolisthesis. Both of them can cause radicular symptoms called sciatica. Sciatica is caused not by the shifting of the vertebral bodies itself, but by the intervertebral disc, which stretches and puts pressure on the nerve roots. As you can see, the intervertebral disc, which is the black structure over here, is very damaged, stretched, and bulges towards the spinal canal. And now the most interesting question, why is it happening? Why the vertebral bodies are shifting in relation to each other? After all, our spine should be strong and durable, right? Well, we have many different etiologies of spondylolisthesis. It can be dysplastic, traumatic, but today I would like to focus on the one which is connected with the instability of the spine. You can't see it in this model, but our spine is stabilized by many ligaments and muscles which are keeping the vertebral bodies in one line. Occasionally, however, these structures do not function properly, allowing more movement in selected region of the spine. And if the structures that should stabilize the spine over here, deep muscles and ligaments, are weak, then we are dealing with something which is called a strong instability in the direction of extension. So, if I ask my patient to do the extension of the lumbar spine, I will feel that these spinous processes are moving in relation to each other. And for such a patient, the hyperextension movement will increase the instability, and this type of movements are forbidden for these patients. And now imagine that with this type of instability, we start doing exercises with hyperextension of the lumbar region, like we did, for example, in sciatica treatment in discopathy, like supports on forearms, supports on straight hands, a lot of this. We would have aggravated the condition right away. So remember, if we are dealing with instability towards the direction of extension, all the exercises that are causing hyperextension of the lumbar region are forbidden. At this point, we need to explain that spondylolisthesis can be in different directions. It can be anteriorly, then we call it anterolisthesis, and posteriorly, and then we call it posterolisthesis. We can have instability both in extension and in flexion direction. Of course, it is me as a physical therapist that must investigate it, and I need to check it before we start the therapy. But for this movie, let's assume that we are dealing with a patient with sciatica from anterolisthesis with a strong instability towards the extension, which is the most common case. In treatment of sciatica caused by spondylolisthesis, when we are dealing with instability of the spine, for example, towards the extension, of course, the main goal of our rehabilitation is to increase the stability of the spine. We need to teach the patient how to contract, how to tighten the specific muscles that are responsible for our core stabilization. I put the patient on his back with his legs slightly bent. We need to find a specific bone, which is the anterior superior iliac spine. This is a sticky bone that you can find on your pelvis. Now we need to place 2 fingers about 2 centimeters towards the center and downwards. At this point, we will feel the tension in the transverse abdominal muscle. We are not talking about contracting large external muscles such as the rectus abdominis or oblique muscles, but we would like to achieve only the contraction of the deep muscles. Transverse abdominis, which is called TRA, is a muscle that acts as a corset, and it is activated prior to extremity movement in order to increase stiffness of the spine for stability. This muscle has been shown to atrophy following episodes of lower back pain. It is not easy to teach a patient the isolated tension of this muscle. Some people use the vacuum exercise, in which patient tries to draw belly button inward towards the spine. But in my opinion, it is not the best way. With the vacuum exercise, a lot of patients compensate with activating rectus abdominis. The way I am teaching how to contract TRA is by activating the sphincters. Sphincters become tense when we want to stop urinating or defecating. Every patient very quickly knows what muscles are involved. So I keep the fingers on the selected point, I take a breath, and at the end of the exhalation, I tense my muscles as if I wanted to stop urinating. I should feel a slight tension under my fingers. Important note, I should not tense the rectus abdominis. This tension should be felt only under my fingers. The remaining abdominal structures should remain loose. The patient learns to maintain this tension for about 10 to 20 seconds. This tension will be the basis of all other exercises. If the patient is able to maintain this tension for 20 seconds, we move on to specific exercises. First exercise. Lie on your back with both legs slightly bent. Engage TRA. Slowly lift the right leg towards your chest. You can help yourself with your hands. Go back and then lift the left leg in the same way. Remember that sciatica symptoms shouldn't get worse during this exercise. Do 3 sets of 10 repetitions. If you feel that the transverse tension has escaped, you cannot feel it, tense it again in the inhale-exhale sequence. Second exercise. Lie on your back with both legs slightly bent. Engage TRA and perform a pelvic tilt as if you want to touch your lumbar spine to the floor. Do this exercise very slowly, trying to keep the TRA muscle tone all the time. Perform 3 sets of 10 repetitions. Third exercise. In all fours, position the lumbar region in an intermediate position. Attention, we do not want to hyperextend, which looks like that. We do not bend the spine in this direction because we have instability to extension and we will worsen the condition. So we start in an intermediate position. Engage TRA and make a gentle flexion movement in the lumbar spine and then return to starting position. Do 3 sets of 10 repetitions. I recommend that the patient walks as much as possible. If walking provokes pain, try using a lumbar belt. I recommend that during the whole day, the patient should try to activate the transverse abdominal muscle as often as possible. So whatever you do, sitting, walking, relaxing, try to keep your TRA tensed. If you can't feel it, inhale, exhale, contract, and keep it as long as you can. In the subacute phase of sciatica caused by spondylolisthesis, when we are dealing with instability towards the extension, when my patient has mastered the contraction of the transverse abdominal muscle, we can move on to slightly more difficult exercises. First exercise. The patient is lying on his back. We start with TRA activation. We put our hands under the back of the head and we raise our head and shoulders. We do not make a full torso bend, but only the upper part of our trunk. We make sure that there is no hyperextension in the lumbar region. During the movement, our lumbar spine should touch the ground. We do 3 sets of 10 repetitions. The second exercise, side plank. We start from the side which is not affected by sciatica. So if I am having a sciatica in my right leg, I start on lying on the left side. We make sure that the lumbar spine is in an intermediate position. Lean on the left knee and on the left forearm. Activate the transverse abdominis and then lift the pelvis up. Hold for 10 seconds. Repeat 5 times. Change sides and do 5 repetitions. Remember about centralization of symptoms. In the further stages of rehabilitation of this type of sciatica, I introduce more planks. Start with the front plank on the forearms in the knee support. Then the front plank on the forearms in the foot support. If it is okay, you can try planks on straight arms and side plank on straight arms. Finish on a side plank on straight arm with a lifted leg. Of course, each such plank should be based on a correctly tensed transverse abdominal muscle. We endure each position for 10 seconds and perform 5 repetitions. And now, what you shouldn't do when you have a sciatica caused by a spondylolisthesis and when you have an instability towards the extension. In the case of instability to extension, we do not make frontal planks with lifting of the legs, which is unfortunately a very common exercise. Don't do it because it causes hyperextension in the lumbar spine, which of course we want to avoid in our case. Also do not the cow position from cat and cow exercise, lifting arms and legs on all fours, lying with your back, lifting both legs at the same time, etc. I hope it is clear. Avoid hyperextensions of the lumbar spine. To sum up, sciatica from spondylolisthesis absolutely requires a consultation with an experienced physical therapist, because in therapy we need to know in which direction the vertebra has slipped and with what kind of instability we are dealing with. We need to learn how to rebuild the proper stabilization of the spine, and we can do it only by activating our deep core muscles. The prognosis in the case of sciatica caused by spondylolisthesis depends on many factors. Very important is the grade. In the case of first and second grade spondylolisthesis, properly conducted exercises can easily reduce the pressure on the sciatic nerve. However, if we are dealing with more advanced slippage, then the effectiveness of physical therapy is significantly reduced. And that will be all. If you have any questions about the movie or about the exercises, please leave it in the comment section below. If you like the movie, leave a thumb up and of course subscribe to the channel for more videos on physiotherapy. Thanks for watching and bye.